Good morning, everyone. We're going to begin the session. This is an important session on CABG in patients with low ejection fraction. And we're going to begin by having Mark Ruel from Ottawa Heart Institute presenting on the evidence for superiority of CABG in patients with low EF. Mark, I'm sure you're going to quote your interesting study from Ontario, from the great province of Ontario.
Thank you very much, Mike. In fact, I will not. I'll keep it very simple. So we just have 9 minutes. This shouldn't take the whole time. It's a little bit of perhaps a bit of a scholarly topic, so my apologies for that. But we just want to review together where do we stand and where do we need to go with regards to performing CABG in low ejection fraction patients with coronary artery disease. So let's first look at the guidelines. So the REVAS guidelines from 2021 and then the chronic coronary disease guidelines from 2023 that you both know well. So in the 2021 guidelines, there was actually a little bit of a typo, interestingly, because they called ejection fraction less than 35. If you want to be very strict about it, it's actually equal or less than 35. This is what the entry criteria was in STITCH. And if you look at the REVAS guidelines, in many guidelines, there's always little typos and little things that will make you cross-eyed sometimes. Anyways, this is a class 1 indication, patients with severe left ventricular dysfunction and multivessel CED. But even that, when we look at STITCH in a minute or two, you'll see it's a little bit of a nuance that STITCH was not always bang on with regards to the type of patients that were operated. Now, in 2023, last summer, these guidelines were published. Dr. Bakain and yours truly worked on those. As you know, it was pretty public that we walked out and slammed the door, unfortunately, kind of at the last minute. But the result from this guideline was first that they got the equal or less right in the table. It's still a class 1 recommendation, so equal or less than 35% ejection fraction. And in it, Faisal and I at the time, there's a bit of an economic analysis which was published in Circulation, which showed that it was about $63,000 per quality adjusted life years gain from having surgical versus over medical therapies. But that being said, these are old data. They're back from the early 2000s, and certainly they apply to the US only, while most of the patients in STITCH, as we'll see, did not at all come from the US or Canada, but actually were operated in non-first world centers, not first world at the time. You could argue that they are today in 2023, but not at the time. So again, I think this analysis, both Faisal and I felt, was not really justified, especially to give intermediate value to prolonged survival and freedom from rehospitalization from heart failure as a result of coronary bypass. So let's go back to STITCH. This is the 10-year, the 9.8-year paper that you all know. As you know, STITCH, I think, started as a surgical ventricular restoration trial and ended up being a CABG trial. So it's a little bit of an afterthought, even though the two arms were truly separated right from the get-go. So in the surgery/CABG arm, there were 1,212 patients. And it took a while for the curves to separate. As you may remember, the 5-year paper was essentially neutral. It was not negative, was neutral. There was no significant difference. And only after 3, 4, 5 years did the curves start to emerge. And the reason for that is here. I don't know if you can see my mouse, but we'll look in more detail at that. There was quite a price to pay in this early trial with regards to operating on these patients. And you may go back to the rematch trial where, remember the ominous results, not only of LVAD implantation in Eric Rowe's paper, but also of medical therapy. Like patients were basically dropping like flies. These were completely different eras with regards to the medical management of heart failure and also the operative outcomes that surgeons and intensivists could get out of them. So, interestingly, STITCH may not be the trial that you think it is. First, again, no offense to my colleagues. I mean, I'd like to go back, okay, by one slide. I've been to Poland in the early 2000s, but at the time, it was not a first world country, and India was not. Today is different, but certainly in terms of especially very challenging patients with LV dysfunction, where most of the patients were recruited, Poland, India, Russia, certainly STITCH was a little bit of a different equation, especially back in 2002. And only about 250 patients out of those 1,212 were operated in what you would consider, at the time, first world. And again, I do want to denote that things have changed since then. And obviously, Poland and India are very, very strong economies now and would be considered on par. But at the time, things were different. Also, the level of coronary artery disease in Stitch, actually, there were quite a few patients who only had single or dual coronary vessel disease. Very few left mains, and only about a third of patients had three vessel disease. So again, not necessarily the patients who you thought you would enroll today. And then ancillary therapies, 20% of patients had an AICD after their surgery. So again, this does not reflect what you would see today in your patient who you operate with an ejection fraction of 28%. And now looking at the outcomes, again, these are difficult surgeries performed in centers perhaps that were not always used to them, but that recruited really well, and the outcomes really show. Here, look at this second line in the first rectangle. Patients who were either dead or not yet discharged within 30 days of operation, 9% in the surgery group. That's a little bit hard to get over that once you have 9% of your patients who drop right from the get-go from the operation and then show a survival benefit later on. Then this is probably the single most important reason why it took so long for Stitch to become positive for surgery. 4% of patients in the surgery group required cardiac arrest, required CPR for cardiac arrest. I don't know about your practice, but if you have 4% of patients who end up having their chest being massaged post-op, there's a little bit of a red flag there and probably a need for M&M. So the mortality at 30 days, this was another analysis that was performed, in fact, ended up being 4.8% in Stitch. And later on, there was another paper that compared similar patients in the STS database and found that the odds ratio, because of the, I guess, antiquated nature of Stitch, for mortality in Stitch was about 2.21. So again, data that involved old methods, not always first world based, old outcomes and old ancillary treatments. Not really the CAD that you thought was really being treated here, and much in both arms, both medical and surgical, has changed since. So two questions I think come out of Stitch. What about operative risk and outcomes? Do they correlate in some way? And what about viability and outcomes? So I'll be brief here by saying first that there was an attempt at looking at the Charlson Comorbidity Index, which obviously was driven very much by our medical colleagues. I think surgeons would have used the STS score. And there was, in fact, in this paper, using the Charlson CI, which uses 16 medical comorbidities, there was no correlation between how sick the patient was and the benefit of surgery over medical therapy. Remarkably, 70% of patients in Stitch were considered high comorbid, severely comorbid. So there's a little bit here, if you look at this forest plot at the bottom, the point estimate is a little bit more in favor if patients had good operative characteristics, not too risky, towards deriving a benefit from surgery versus if they were severe, but not enough to have a significant interaction p-value, very far from it. Now, viability was an interesting story as well, and that got published in the New England, as you all know. And interestingly, whether someone has viability or not, this was about half of the cohort of Stitch. Remember, 12th well, now down to about 600 patients. The survival was not that different. So patients without viability will also derive some benefit to having surgery. Here, without viable myocardium, with viable myocardium, no significant interaction. CABG was better than medical therapy in both groups. Now, as you can see here, there's a little bit, you could be strict and say that the only subgroup really that showed a benefit was those with viable myocardium surgery versus medical therapy, but the p-value for interaction was not significant. So really, one should not call it this way. And interestingly, with regards to no improvement or improvement in EF after surgery, there was still relatively little differences in survival. So I always say that when you operate a patient with LV dysfunction, I think my colleagues will speak a little further to this, you're trying to achieve two things. You're hoping that you're going to improve left ventricular ejection fraction, but you don't always, especially if the patient has no viability to start with. But at least with CABG, you can try to preserve what they have, and that's really important. If someone has a 21% EF with three-vessel disease, they don't have a lot of luxury that allows them to have another big myocardial infarction. So protecting them for the next 5-10 years is tremendously important. So I'd say if the patient's operable with high-grade CAD, which was not always the case in Stitch, go ahead, consider OpCab, and simpler is better in my opinion. This is not the type of patient to start wasting time and energy on multiple arteriografts, but that's a different topic. I'll finish with a little bit of a nudge to our PCI colleagues. The Revive trial was about half the size of Stitch, about 600 patients. And as you all know, the distribution of coronary artery disease was in fact more severe than in Stitch. So lots of left main, lots of three-vessel disease. There was no single vessel disease, which was about 25% of the Stitch trial in the Revive trial. But it was essentially a wash. There was no difference at all with regards to the primary outcome, which was either death or hospitalization for heart failure. And there was not even a signal with regards to the subclinical endpoint of improvement in left ventricular ejection fraction. So a great disappointment for PCI. And obviously everyone awaiting further data, but there's no evidence even at 6-7 years that these curves are going to diverge. I'll finish with this. There's now, because of the caveats of Stitch, I think we need a new randomized trial. Dr. Freems, Dr. Godino, and others have gotten together and included some of us, including yours truly, to design this Stitch 3C, which has already been funded by CIHR, which is like the Canadian NIH. And we're hoping together, and I would invite Steve or others to comment further later, to enroll 754 patients. The primary composite outcome is, as you see here, it will involve patients with an EF of less than 40%. Who have multivessel or left main CAD, and where the heart team feels that it's appropriate for either PCI or CABG. So CABG is superior in CAD with LV dysfunction, but we do need to improve our outcomes. We need to define the modern outcomes as well. And to this, I will leave you with one consensus statement that the ATS got together, first authored by Faisal, who perhaps we'll speak about it a little later. And again, interestingly here, Class 2B recommendations are given to multi-arterial grafting and to off-pump. I think if you can do off-pump very comfortably, this is really the gold standard territory of off-pump surgery, because you never worry whether you're not going to be able to wean from cardiopulmonary bypass. Simply don't go on it and just do it without it. So I'd like to thank you, as our leaders from ICC do when we have the pleasure and honor to invite them at the STS Coronary Conference. We do the same as well. There are two great meetings that deal with coronary surgery, and please attend both of them. And the STS Coronary Conference will be in Miami, June 7 and 8, 2024. Thank you very much.
Thank you, Mark. Thank you, Mark. We'll hopefully have some time for questions at the end of this session. So we'll go on now.
So next topic is minimally cardiac surgery for CABG patient. So Dr. Mariana Cabasco. Please.
Hi, thank you for having me here today. My name is Marisa Savasco. I'm one of the heart surgeons at Penn. I'm privileged to be part of this panel. My disclosures. So as just a brief overview to start my talk. So why do we need to talk about temporary MCS in CABG patients? Well, we know, as Dr. Well just showed, there is a benefit to bypass surgery in low EF patients. And there's a significant number of patients who fall into this category. But who would potentially benefit from temporary MCS? And then what are the options? How should we do this? And then if I have some time, I'll give a case as an example. So as Dr. Well just showed, he went over Stitch trial very nicely. Everyone here is familiar with it. Results at 10 years, it looked at patients with EF of less than 35%. So the average EF in this study was around 28%. They were randomized to medical therapy versus CABG plus medical therapy. And we can see the long-term outcome shows that there's about 20% reduction in death from cardiovascular causes versus optimal medical therapy alone. But this red circle here, it shows it's really the first 2 years of the study that's the highest risk of mortality. The surgical risk is weighted up front. And as my previous speaker showed, there's various reasons for this, but how can we mitigate this risk? a paper by Dr. Well himself, also showed there's a benefit to CABG, specifically over PCI in patients with low EF. At the time this was published, it was the largest published study. It showed long-term outcomes of PCI versus CABG in patients with coronary disease and reduced EF. And we can see again, the curves really diverge over time. So risk of all-cause deaths from cardiovascular disease, MACE, subsequent revascularization, and hospitalization were higher in patients who underwent PCI. But again, in the beginning, if you look at the curves, they're very close, they overlap. So back to this upfront risk. So what can we do? Now here's a paper from Veli Tapkara and his colleagues at Columbia. They looked at a New York State database of over 55,000 patients, stratified into 4 categories of LV function. And this included around 10% patients who had off-pump bypass. So this is just post-cardiotomy shock. So low EF patients, you can see, had the highest risk of in-hospital and 30-day mortality, around 4 times the risk of those patients with relatively normal EF. So EF over 40% was considered relatively normal for this study. Another study, STS database, Dave Shahian at MGH. This is back in 2009, but still, this was a 4-year study. From 2002 to 2006, there were 750,000 CABG patients in this study. 10% of those patients had an EF of under 35%. Patients with an EF of under 25, 7% mortality. 25 to 34, 5% risk of mortality. Now, low percentages, but so 10% of these patients, but that's a disproportionate risk of mortality. And that equated to around 4,300 patients who died. So we know that we're going to continue to perform CABG for patients with low EF. We know that there's better long-term outcomes in medical therapy or PCI for this patient population. Plus, this is better. Patients can keep their heart instead of going on to heart transplant or VAD if there's no other option. But what do we do about this upfront mortality? So first, we have to figure out who might potentially benefit from temporary MCS post-cardiotomy. So who's at risk? So we know that low EF, you're at risk for potentially needing support. If you're going emergent or urgent CABG, if your index is low going in, these are all like intuitive things that we know. If you come in with end organ dysfunction, you're in shock when you present. The phenotype of diabetes and kidney disease is also at risk. Poor coronary targets can lead to incomplete revascularization. We all know those patients. And other things like prior history of radiation, RV dysfunction, or concomitant valvular lesions also put you at risk. So we also know if you come out on rocket fuel, the patient's going to really struggle. So vasoactive inotrope score. The higher the vasoactive inotrope score, the higher your postoperative mortality. Inotropes, we all know, increase myocardial oxygen demand, increase the risk of arrhythmias. Your ICU will not extubate your patient. So we really want to avoid that. But when inotropes are not enough, what are our options? So we have balloon. We're all familiar with balloon. A lot of our patients may even go into the OR with the balloon in place already. And what are its advantages? Well, afterload reduction. There's a modest afterload reduction. It improves coronary perfusion. It's typically easily inserted, easily removed. However, it only modestly contributes to LV unloading. It doesn't work well with arrhythmia. Patients can't ambulate unless you put it in the AX, and femoral artery access issues and leg ischemia, known complications. And in fact, the 2020 EACTS expert consensus on post-cardiotomy support, this gives it a 3C recommendation, so really not recommending balloon for this patient population. ECMO. All familiar with ECMO as well. So what are the advantages of ECMO? Well, ECMO is essentially a cardiac output machine. You rapidly reverse your systemic malperfusion. You give them cardiac output. But it's also an afterload machine as well. So you increase your LV afterload, which leads to LV distension, pulmonary edema. You can get cardiac stasis, intracardiac thrombus, really problematic. Patients are typically not ambulatory unless you're putting it in a sport model configuration. And of course, there's a high risk and complication profile as well. Bleeding risk, limb ischemia, prolonged hospital and ICU length of stay. Meta-analyses have been done, shown that there's a very high risk of complications and poor one-year survival. Tandem heart. So I'm sure some of us have familiarity with tandem heart. Not that dissimilar from ECMO, except you're venting the LA. But again, it gives you cardiac output. It reverses malperfusion. But it's at the cost of Septal puncture, patient still non-ambulatory, you're still putting stuff through a pump and an oxygenator. Holger Thiel's trial, looking at balloon versus tandem heart. Again, there's no benefit to tandem heart over balloon. So really hard to prove that any device is beneficial in post-cardiotomy shock. So I'm going to move on to Impella support device family. So these are microaxial surgically implanted heart pumps. They're put in through the axillary or through the aorta. You can put a graft on the aorta. It unloads the left ventricle. It reduces ventricular work. Patients are able to get out of bed very early on, facilitates early ambulation, and decreases your vasoactive inotrope score. I really like this study by Naveen Kapoor's group from Tufts. He put conductance catheters in a patient who ultimately went on to get a heart transplant, but they showed the pressure volume loops of these patients, one in the LV, one in the RV. And so not only do you see improved hemodynamic performance of the LV, but you actually see some for the RV as well. So there is some sense that not only is it LV unloading, but it's RV unloading. Dean Smith at NYU, this was an early study, but of the earlier generation Impella 5.0 and LD devices. Single center retrospective study of 13 patients. Again, average EF of under 20%, STS score of around 5. There was a very low rate of renal failure and 0 mortality. From our colleagues in France, another study, again, looking at the earlier generation, isolated CABG patients, patients with isolated valves or CABG valve. 86% AX approach, but more than 70% went on to wean from the Impella and all recovered their heart function. Cleveland Clinic recently published their approach to high-risk CABG using the Impella device. They have a new way of pre-oping these patients and thinking, do they need temp MCS as coming off for high-risk CABG patients? Again, they avoid the post-cardiotomy shock. It's easy to insert. They do a pre-op or pre-sternotomy. And again, it minimizes this post-op vasoactive inotrope score. It avoids that 48 hours early shock stage. And again, you can revascularize patients, let them keep their own heart. As much as I love to do heart transplants for patients, they don't have to go on the wait list. They don't have steroid post-op. They don't have immunosuppression. Heart revascularization over heart replacement. Impact might help figure this out, whether or not there is any benefit to the Impella device. So I just have a brief case. I'm kind of out of time, but just a classic guy, 72-year-old comes into the ER, EF of 10% and moderate MR. He was tachycardic. He had pulmonary edema. You could see he had transaminitis. His creatinine was elevated. His BNP was over 11,000. His troponin, he had a troponin leak. He's had 1 month of symptoms, so he actually came in almost like a heart failure admission. You can see his EKG has VT, non-sustained VT. Here's his echo on admission. So really not much going on here. But given his age, 72, isn't going to be a transplant candidate in many programs. Here's his cath, though. He has really nice targets. He has 50% left main, Prox LAD, high-grade circ disease, and RCA disease. Right heart cath done at the time showed he was wet. Index was 1.6. There was definitely room to optimize this patient, but his STS score is around 9%. So we admitted him, we diuresed him, we cleaned him up. But this is a note I thought was really telling from one of our senior cardiologists. This patient's at risk for recurrent ischemia, death. He is a high risk and STEMI. He has severe LV dysfunction, so his in-hospital mortality is significant, and surgery is at the higher than usual risk. So how can we fix this? So we know that he had several risk factors for post-cardiotomy shock. His EF was under 20. He needed an urgent operation. This was not an elective case. He was older than 70. He had left main disease and triple vessel disease. This was his EF in the OR prior to starting the case. He also had moderate MR. So again, optimized him and then took him to the OR, axe graft, almost placed the device, the penultimate step prior to placing the device, did a CABG ×5, and then prior to coming off, put the Impella using TE guidance, fully reversed the patient, take him to the ICU. He was extubated that day, able to start aggressively diuresing, especially with the enhanced cardiac output that you get up front from the device, as opposed to kind of waiting for some of the heart function to recover. The device came out by postoperative day 4, and he did well. Prior to discharge, his EF was up to 30, 35. And then this was kind of an older case, but his EF on long-term follow-up was back up to 40% with really minimal trace to mild MR. So in some, CABG for low EF patients is beneficial. It's not going to go away. We need to recognize that these patients are at risk for higher upfront mortality. And there are things we can do to mitigate that risk. I think we're getting signal from the literature that there is a benefit to early temporary mechanical supports, particularly with the LV unloading device. And these are things that we need to consider, especially in the US with our era of public reporting. In Pennsylvania, all our outcomes are reported, and STS star rating, when the difference between one patient death and two patient deaths can cause a programmatic change in star ratings. Not to say that's our metric alone, because it's really a patient life. Thank you very much.
Thanks, Marisa. So I have to move on to the next session, next talk. So by Dr. Faisal Bakin. Oh.
You do the other.
Topics is cardiopulmonary bypass and cardioplasia techniques for CABG in patients with low ejection fraction.
Good morning. Again, pleasure to be here today. Well, when we deal with patients with low EF, there's a preoperative phase, intraoperative phase, and postoperative phase to achieve success. And obviously the preoperative phase depends, I think, in my opinion, on targets more than anything else. If you have good targets, you're going to do well. But also we look at viability, we look at the RV function, we look at the extent of dilatation of the ventricle, and the patient themselves. I mean, is it a frail patient, robust patient, and what are the physiologic risks? And then the postoperative phase, the importance of medical therapy, like Dr. Fakou outlined. But when we look at the intraoperative phase, it's all about complete and reliable revascularization and good protection. And ladies and gentlemen, as of last night, I was able to identify the best cardioplegia for myocardial protection ever. It's not Buckberg, it's not Del Nido, it's not microplegia. It's developed right here by ISCAS. It's called the ventricular velvet Negroni. I strongly recommend it. So let's start with our patient who didn't get that, but managed to do well. 47-year-old male with hyperlipidemia, diabetes, ischemic cardiomyopathy, EF 15%, and congestive heart failure. And he's got reasonable targets. You can see he's got some circ disease with some reasonable OMs, an LAD target, and you can see that the PDA fills retrograde from the left side. The cardiac index on right heart cath was actually surprisingly 2.0, and we'll come back to that later. And the PAPI, which is a measure of the pulsatility of the RV, was 1.5, which is kind of borderline. This is how the echo looked like. And as you can see on the left, the LV is dilated, kind of thinned out a little bit and weak. But also what's concerning on the right side is that the RV didn't look that hot either. There was moderate RV dysfunction. The viability was interesting, and it showed that there's ischemia and there's significant viability, and we felt that this will be helpful. Now, we use viability. Dr. Ruel mentioned that it didn't have an impact on prognosis on stitch, and maybe that is true. Maybe that is true. But what is also true in our personal experience and in talking to others is that if they have viability and good targets, their perioperative course is much easier. They fly off pump, they don't need a balloon, they do great. But if their viability is marginal, then they may need some help and they may struggle a little bit in the perioperative course. So what we did here was a CABG times 4. Now, we did use multi-arterial grafting because this is the Cleveland Clinic, but we'll come back to that later as well. We did a LITA to LAD, RITA to OM1, and then we used veins on other targets. We did put a balloon pump to kind of make the perioperative period smoother, but they didn't require it beyond post-op day 1, and the patient did really well and left the hospital on day 8. And this is the 8-week follow-up. You can see on the left side that LV is beating much better, now 40%, and that RV has come back. So that was very gratifying. Now, this is another high-risk CABG. This is a lady that came in with STEMI, only 31 years old, with spontaneous coronary artery dissection, seen at an outside hospital. They said, well, there's nothing we could do. You need a VAD. They put a balloon pump in her and sat on her for 24 hours. Her husband insisted on her being transferred to the Cleveland Clinic. Now, when she arrived, I thought, well, maybe they were right. I mean, it's STEMI, it's 24 hours later, maybe a VAD is the right thing to do. But she's very, very young, and she was having chest pain as I was talking to her, and nitro was hanging, and she'll feel better with the nitro. So I said, well, I'm going to take her to the OR, but I'm no fool. So I made sure that a VAD was standby with the whole team standby, and I took her to the OR. Now, what I found was a good LAD target to land on, but on the lateral wall, it looked blue. The whole vessel was thrombosed. So what I did was open that, actually it was a big ramus. I opened it, and I just found clot. You couldn't tell what's true lumen, what's false lumen. She said, we'll do it like an endarterectomy. We'll just scoop everything out and give tons of cardioplegia, mostly retrograde, to flush out any clot. And we used direct retrograde. When what I mean by direct retrograde is that you put the cardioplegia catheter directly under direct vision with a purse ring into the coronary sinus through an open right atrium. And we massaged and milked out all that clot, and we put a graft there. Well, she did well, and she had good flow in that graft. She had actually 45 cc's in that graft by the flow meter, and her Lima to LAD was excellent. And before discharge, I said, well, I want to do some quality control here just to see what kind of anatomy we have and what are the convos doing. So that's the Lita to LAD. It looks nice to the distal LAD. And this is the vein graft with a very long hood, because I splayed that ramus open for a long distance, and you could appreciate here that very long hood. And it was obviously patent. And she went home day 5, and her EF improved to 30%, which is a marked improvement. That's another disaster transferred to us for another reason. 42-year-old should have had a David procedure, but unfortunately, due to inexperience, received a biologic biobental. They couldn't come off pump, so they rightly bypassed the left system and the right system. I'm sorry, they bypassed the left system. Let me see if I can play that. Yeah. But as you can see here, the left main is compromised. I don't know how they did that, whether the button was twisted. Something happened there. They couldn't get her off even after the bypass, and they transferred to us with an open chest and ECMO. Well, this is the reason that she couldn't come off pump even after the bypass. That's the vein to LAD, severely compromised distally here. And as you can see, the vein to the OM is compromised distally as well. We took her to the OR and revised those anastomosis, and she was weaned off ECMO and did well. As Mark Rowell mentioned, we were involved in writing this document together, an expert consensus document about managing patients with low EF. And we should remember that many patients will benefit from isolated CABG, but some would require an adjunct procedure, such as a mitral valve repair or replacement or a tricuspid valve. And some will require temporary assistance. And we'll come back to who might require that. But some clearly don't belong to CABG, and they just require a VAD. They're far down the journey of heart failure that CABG is going to be too high risk or of limited utility, almost futility in those cases. And there are transcatheter therapies, PCIs, and medical management only that we won't get into. But coming back to the intraoperative strategy, I mean, yes, you could do it off pump if you're experienced in doing off pump, and you could achieve complete revascularization expeditiously without hemodynamic compromise. You don't want to be lifting the heart and be on 5 of epi and 20 of levo. I mean, you'll be killing the kidneys and compromising the liver. So our preference, I know that others prefer other approaches, is to use an on-pump, and that's reflected by the literature and what the consensus of the expert indicated, that in general, patients with low EF should then go bypass with cardioplegia, and blood cardioplegia is the preferred way to protect the heart, as non-randomized evidence would indicate. Now, with regards to cardioplegia, you can never give too much. You should give antigrade plus retrograde, consider the direct approach like I've described, and give down the grafts. That's a beautiful way to supply totally occluded vessels specifically. Systemic cooling can be helpful, and always control the patent ITAs if you're doing a redo CABG. And Mark touched upon this. We don't feel strongly about using multi-arterial grafting, although young people, we tend to try and use them. But high-risk features are decompensated heart failure on inotropes, temporary mechanical support already in place, poor coronary targets, and other things that Marissa mentioned before me. And we published about that, again, as was pointed out earlier, and I'm going to just focus on our systematic approach to those who finally qualify for a surgical options. Some will never come to surgery, some can never be optimized, and they get triaged for a transplant. But let's say that they're ready for surgery. Here are the key features that we use at the clinic to guide us. If the PAPI, which is a measure of the RV function, is greater than 1.2, if the cardiac index is greater than 2, if the CVP is less than 20 after medical optimization, with or without an intra-aortic balloon pump, then we proceed with CABG, and that CABG is usually low to moderate risk. But if those criteria are not satisfied, we tend to use an Impella-assisted CABG as a prophylactic approach. And we have published our series with over 200 patients with the use of Impella-assisted CABG with a mortality of less than 2% in those very high-risk patients. So in summary, how do you optimize outcomes in low EF CABG? Medical optimization is key. Don't go into surgery with multi-system organ failure. That's a recipe for disaster, no matter how technically brilliant the procedure is. Meticulous planning, we get a CT scan. It gives us lots of information, not about just the quality of the targets in the aorta, but also access to place the Impella through the right subclavian. It should be an expeditious operation. This is not a teaching operation. Complete revascularization, robust myocardial protection, and experience counts. Thank you very much.
Thank you very much. A great presentation, very insightful. The next talk is by the person that probably taught most of us off-pump surgery, Paul Sergeant, and he's going to address techniques for OPCAP in patients with low EF.
Thank you, Mr. Chairman. It's an extreme privilege to be here today in this audience of experts. So the time of meetings as we have today is finished. We just go to ChatGPT and we ask ChatGPT what we should do. And in fact, that's what I did. And astonishingly, ChatGPT gave me an answer. That was already exciting for me. It gave an answer with 9 possible steps, and that was also interesting. So already ChatGPT understood that if you want to do off-pump coronary surgery in low ejection fraction, there's a number of issues. But then when we looked further into ChatGPT, in fact, nothing came out of it. It was just blah, blah, blah. That didn't help us. So too bad, ChatGPT, too bad. We will have to continue meeting in New York. We created another solution. I've had an app on OPCAP surgery already for more than 12 years, and we've now created a new application. It's called mycvsurgery.com. It's in 7 languages. It has been created in 7 languages. Some still have to go under compliance issue, but they will be opened up very rapidly. It has videos, it has chat rooms, and it has also something called the debrief procedure. So let's talk about OPCAP in patients with low ejection fraction. It's not difficult, but it is different. It's not an escape approach when conventional coronary surgery is considered too high. It is based on traditional rules, of course, and assessments of viability. And the fact that you have OPCAP experience in SAY is irrelevant. What is relevant is that you have strict written down sets of standard operating procedures for each team member, for the anesthesiologist, for the nurse, for the perfusionist. A strict compliance also to these SOPs. So you don't just have to have the SOPs, but you have to comply to them, and certainly comply to them with the experience in the low ejection fraction. Of course, after each procedure, you need a debrief, and that's why we have created the debrief module on this application. I think it's the first time in surgery that there is a debrief procedure has been proposed to you. And of course, you need an extensive evidence-based experience in OPCAP. Your own experience, not the one published by Taggart or by Puskas, but your own experience. You need to document your own experience. In fact, OPCAP in low ejection fraction is easier than OPCAP in severe left ventricular hypertrophy. The severe left ventricular hypertrophy, what we call, with all respect, the pig heart, is very difficult, but this is in fact very easy. So let's look at our experience. OPCAP, when we did patients with low ejection fraction, we had a habit in Leuven of doing around 2% of the patients with a balloon pump. I learned my balloon pump in 1972. I know it's an age where some of you were probably not yet awake, but it was Boluki from Miami who pushed us into the formal balloon pumps. We have a strict procedure for treating patients with low ejection fraction, and there is some confusion. You have patients with acute infarct, and you have patients without acute infarct. For the acute patients, we have very strict procedures. We're not going to go into the detail here, but we have very strict procedures whether to do that procedure in an acute infarct, the same in on pump or off pump. Let's look at the rest of the lecture, which in fact discusses the non-acute infarct, low ejection fraction situation. And the first thing is that the routine use of Impella, I know that some surgeons use that, and we have 20 years experience with the Impella, so 20 years, it has not been very convincing. It has a number of difficulties. It has a cost issue for some economies at least, but it's not very convincing. So it's okay if you do it, but it's not very convincing. Let's look at the filling in these patients. Well, the monitoring of the pulmonary waveform and the pulmonary artery pressures is essential in OPCAP in these patients. And why is that? Because you have to monitor the compliance of the left ventricle. If your technique is inappropriate in the sense that you've increased a little bit your mitral valve insufficiency or mitral valve regurg, you need to know from the first second. And you can only do that by looking at your waveform. It's something the way for few people monitor the pulmonary artery pressures, but even more important is the pulmonary artery waveform. There's an additional benefit of doing OPCAP because you work with a filled ventricle, and certainly if you're going to do complex arterial revascularization with sequential anastomosis on the backside, you like to work with a normally filled ventricle versus with a cardioplegic empty vessel. So let's look at our heart rate. Well, the heart rate should be as my own heart rate now, physiological. We will beta block, of course, if the heart rate is more than 75, and we'll pace if the heart rate is less than 60. Very important in these patients with low ejection fraction is the presence of a conduction disturbance. Left anterior hemiblock, right bundle branch block, left bundle branch block, or atrial fibrillation demand a specific approach and demand pacing before you start the surgery, and not just placing the pacing catheters, but checking them. You absolutely want normothermia. We don't allow a single drift of temperature below 37 degrees. So it has to be normothermic situation. Very strangely, we do not accept enough pump inotropia. We absolutely do not accept inotropia because inotropia is not physiology. We use a low dose of specific vasoconstrictors. That's because our patients are very warm. Our patients are very often in the operating theater 38 degrees, which we monitor up to 1/10 of a degree. And the solution is very easy. When the patient is losing temperature, we warm the room up to 30 degrees if needed. We don't care what a surgeon thinks or what a scrub nurse thinks. We just warm it because the only thing that is important is the patient. We do use milrinone. This is not an audience with experts on the milrinone, but I can tell you that we consider milrinone a very important drug. It's not an inotropic drug for treating and supporting the patient during this procedure. Our enucleation process is a very standard process. It will be more explained in the next lecture I will give tomorrow. You take the left ventricle out with the right hand, you change to the left hand, place 2 fingers, in fact you elevate the heart, and then you place your anchor stitch. We then, in that loop of that anchor stitch, you place a sponge. And this whole process takes only 5 seconds. We do this in patients basically in cardiogenic shock even, and it's absolutely done by the resident. It's not done by me, it's done by the resident. They're trained to do so. And then you have an enucleation process. We always use as well an apical positioner as, of course, a local anastomotic stabilizer. And why do we use the anastomotic, apical positioner? And I'll explain that in a few seconds. We changed the position of the apical positioner because one of the issues is sometimes the anterior wall is the only section that is still moving. If you have a massive infarct in the lateral inferior posterior section, you're not going to place an apical positioner in the anterior wall because that's the only section that is still contracting. So that's the excuse that we do to place our apical position on another side. Excuse me. So what you want basically to have is an optimal environment where you have normal physiology, where you can work in a normal situation with no stress for the surgeon. Maybe one of the most important things, and I've read with a lot of interest the previous lectures, is the anastomotic technique. The surgeons will have to learn to work in a very reduced airspace because the reduced airspace is what you have on the backside of the heart. We're talking about 1 to 2 centimeters airspace, certainly in low ejection fraction. And that demands another technique. I was learned to do the parachuter technique. I used it for 25 years of my career. In probably 15,000 patients, I used the parachuter technique. Today, we consider the parachuter technique totally out. We consider it out for 2 reasons. And the first reason is you need airspace to do your parachuter technique. You cannot do that in 1 centimeter airspace. And secondly, we know that when you bring your 2 components of the parachuter technique together, you have a jiggly effect. You have a massive cutting effect on the walls. For those unfamiliar with Mr. Gigli, Italian gynecologist, 1890, published the Gigli saw. It was done for the pubic bone for the ladies that were delivering where the baby got stuck in the birth channel. Not something you want to have your coronary walls done it. So, of course, our default procedure is full arterial revascularization, no veins, based on the 2 internal mammary arteries in these patients with low ejection fraction. That's why we've set up 12 years ago a very large global project on training surgeons. We've now trained more than 11,000 surgeons in this project. The project is called My Virtual Surgery. We're here in the US, and so I put a plot in the different academic units where we're now implementing this project. It's done through webinars, it's done through semi-automated learning platforms. For those interested, just contact me and we'll help you. And finally, I want to finish up in this new application. We have created a debrief procedure. You go to programs and you will find the debrief procedure. In that debrief procedure, you will be guided in the implementation of your surgical process. You will not undergo all the questions. You'll only go questions related to your previous answers to optimize the flow. You can submit as many procedures as you want. It just will guide yourself. It will give quantitative assessments and proposals, but also numerical quantitative assessments. So you'll also get the value so that you can see how your value improves through the process. And I thank you for the privilege of this presentation.
Thank you very much. We move on to the last presentation, and then we probably have some minutes for questions. It's going to be presented by Dr. Kirov. It's mitral valve surgery in CABG patients with low EF.
Thank you very much, dear Chairman, ladies and gentlemen. Before we start talking about mitral valve surgery in CABG patients with low ejection fraction, there are 2 important questions that we have to address. The first was already addressed by the previous speakers, and it is why do we have to perform CABG in patients with low ejection fractions? Just to summarize, we have the STITCH trial results, which show a survival advantage for CABG after 10 years. And in contrast, we have the results of the REVIVE trial, where the survival curves overlap and there was no survival advantage. So we can safely conclude that CABG, but not PCI, prolongs life compared to medical therapy in heart failure. And then I come to the second question: why do we perform mitral valve surgery? And here things get a bit more complicated. So we did a meta-analysis of reconstructed time to event data for patients with mitral regurgitation that did not receive any surgery or intervention. And what we found out is that the degree of mitral valve regurgitation correlated significantly with their survival. And when you have severe MR, you're much less likely to live longer. Well, what about eliminating MR? Does it prolong life? And we also did a meta-analysis of reconstructed time to event data and analyzed the patients after surgery or intervention. And if your repair rates if your repair was not successful and you had mild, moderate, or severe MR, we found that that correlation remained. You have low survival if you have severe MR after surgery. So, how about functional mitral regurgitations? The previous slides were for both structural and functional, but if we concentrate only on functional mitral regurgitation, and this is a slide showing the results of patients with moderate to severe MR and poor ejection fraction, and 95 of those patients here in this study received repairs. You can see that the event-free survival was better with mitral valve surgery than without mitral valve surgery in those patients. So we can say, based on those slides, that eliminating MR might probably prolong life. So how about patients with ischemic MR and reduced ejection fraction? Well, if we have moderate mitral regurgitation in CABG patients, the observational evidence and also the randomized data say that you have no survival advantage if you perform concomitant CABG and mitral valve surgery. And you can see here on the right-hand side, the New England Journal publication showing both survival curves overlapping. So when do we think about mitral valve surgery in CABG patients with low ejection fractions? And there are two potential scenarios. The first one is if we have severe primary MR, in cases like endocarditis, papillary muscle rupture, and acute coronary syndrome prolapse, and this is more seldom in those patients. Or we have severe secondary or functional mitral regurgitation, which is more often the case. So that's why we'll concentrate in my talk only on the second part, as it is more often. So if we take a look at the guidelines, what the guidelines say, if we have CABG patients with functional mitral regurgitation, they might be candidates for concomitant CABG and mitral valve surgery if they are appropriate for surgery based on individual characteristics. If we have end-stage LV or RV dysfunction, they are probably better off with heart transplantation or LVAD. But what does appropriate for surgery based on individual characteristics mean? And are patients with really severe ejection fraction candidates for concomitant surgery? And we can probably see here a very nice study showing the outcomes of conventional cardiac surgery in patients with severely reduced ejection fraction, less than 25%, and the authors stratified the patients according to the type of surgery they received. So you can see on the bottom line, the dashed line, that when you have CABG and valve surgery in those patients, the results are well comparable to CABG surgery only, even though they are worse. And if we're more precise, those patients had 80% 1-year survival and 61% 5-year survival. Although those concomitant surgeries did not include only mitral valve, most of the patients had mitral valve pathology, so I think they are relevant for the question that we have. Predictors of mortality in these high-risk groups were previous heart surgery, age, kidney dysfunction, and further reduction of the ejection fraction. So, if we address functional mitral regurgitation, we have a significant, or with repair, we have a significant problem. And that problem is that mitral regurgitation returns. And here you can see that after 1 year, approximately 30% of the patients have a return of severe MR. And we also addressed this issue systematically, and we investigated all publications reporting the degree of recurrence of mitral regurgitation that was severe in the follow-up time. And you can see here the individual dots are individual studies. And a great number of those studies had recurrence of more than moderate MR in up to 4 years after surgery. And if we translate that in the previous slide, we'll see that this automatically translates in worse survival. So what can we do about it? Probably modify the ring design, but the problem is much more complex because we do not have to address only the annular plane because we have a ventricular problem in those patients with low ejection fraction. That's why subvalvular strategies have been developed, as here shown 2 techniques, the Crone or the ring plus string techniques, which have different approaches. The Crone technique via atriotomy, when you put a traction suture to the posterior papillary muscle, and the final tension is performed in the arrested heart, or on the right side, the ring plus string technique, where you have a horizontal aortotomy, and then the final tension of the string is done on the loading beating heart under TE guidance. And we in Jena, we have developed our own subvalvular strategy, which we call the ring new string. And briefly, we place a noose to the anterior papillary muscle, and then we place a string on the posterolateral papillary muscle, which goes through the noose, is then taken out on the mitral annulus in the P2 segment, and then attached to the ring. And just to show how it's done, I've brought a video. You have here the typical patient with functional mitral regurgitation, and here's the surgical technique. You anchor the loop to the anterolateral papillary muscle, then the PTFS string and both ends of the suture are guided through the noose. Then you exteriorize in the P2 segment in the atrium, and then fix the suture ends to the ring. The final adjustment, we do it after the saline test, and then tie it without putting a lot of pressure. Here is the postoperative result, which shows a tight valve, but this is not the most important because most of us produce tight valves postoperatively. What matters is the medium and long-term results, and we have performed this technique in 43 patients, and we have so far a midterm follow-up of 4 years where we have a freedom from severe MR of 100%, and we have a freedom from moderate mitral regurgitation of 86%, and hope that we can show the long-term data in a couple of years. So I would like to conclude. CABG prolongs life in patients with a reduced ejection fraction. Generally, there is a correlation between the degree of mitral regurgitation and survival. In patients with reduced ejection fraction and moderate mitral regurgitation, CABG and concomitant CABG and mitral valve surgery is not associated with any benefit in survival. And in the modern era, CABG and valve surgery in patients with reduced ejection fraction can result in acceptable outcomes. However, if we repair the mitral valve, we have to be sure that the repair is durable. Thank you for your attention.
Can we have the speakers join us at the front? I think we have some time for discussion. As Mark comes up to the podium. So Mark, is viability necessary in these trials? And the whole issue of viability has come into question not only in trials of revascularization, direct head-to-head, but also, of course, in the ischemia trial, where searching for ischemia seems to have fallen on some tough times. So I'm just wondering, given the data from Panza, from Stitch, and other data, should we be predicating our decisions on viability?
So, great question. I would say three things to answer briefly. Again, to reiterate, there are two things we're trying to accomplish. For CABG, in the presence of LV dysfunction, we're trying to improve the EF, but barring that, we're trying to preserve what the patient has. And these patients don't have luxury for another anterior or lateral MI, right? So that could equal to their demise. So I think, if a patient is otherwise low risk with high-grade proximal LAD or proximal CAD, you do it. Now, no viability probably means, at least when we look at the sub-analysis from Stitch, which was about half the patients, it probably means in most patients that the LVEF is not going to go up. But that doesn't mean that the operation is not going to translate into a survival benefit. As was shown, there was no interaction in Stitch, despite the very high early price to pay on. And I would say the last thing is sometimes viability. I think we've all done it. Viability is a nice way, when it's absent, to not operate on a patient. And I think we've all done it. Someone with heavy comorbidities on dialysis, all this, and you're not really sure whether you're going durable VAD, destination VAD versus CABG. I think viability kind of helps you make that decision. So often it's a little bit of a excluder rather than an includer, and I think we've all sinned, but certainly I have done that in the past.
Thank you, Mark. Do you have any questions from the audience? Maybe we can go to our other chairs for comments.
So viability is very important, depend on the LV ejection fraction. I agree with you. So in your talk, you focus on the multi-arterial grafting. It's no need for low ejection fraction patient, but Professor Paul Sujahn is very difficult, difficult and between difficult and different is completely different. So, what do you think of Paul Sujahn?
Paul first, and then I'll answer to Paul. If I can.
The OPCAP implementation globally has failed. And the reason it has failed has nothing to do with OPCAP. It has to do with the implementation process. OPCAP does not have the safety net of the extracorporeal circulation. So this means that since it does not have that safety net, we have to monitor so that we know in real time what is happening to the patient on the one side, but on the other side, we must not induce anything. So to give you an example, I will tell the resident, we've just finished 5 arterial anastomosis on the backside, and we have had 2 extra systoles for the whole procedure. And you're now going to close the procedure, close the chest, and with the suction, you've just touched the left atrium 3 times, and in fact, you created 10 extra systoles. So the rules are so strict that you will not touch the heart, so that with the hands of the surgeon do not touch the heart except for these 5 seconds that we have done. Every single manipulation, every single component, and that's not difficult. We're serious people. If you look, and in fact it was cited by a colleague yesterday, is that to land a jet plane on an aircraft carrier, these guys are 23 years old. That is difficult. I can tell you it's difficult. I've flown on the piggyback on a military jet. You don't want to go through that experience. But these guys have been trained to do so. And we have stopped training surgeons. We have stopped training surgeons to follow strict SOPs. I challenge this audience. How many audience departments have strict surgical SOPs going into the last detail, what to do, when to speak to anesthesia, when to have the response of anesthesia, at every single step? We have that since 30 years. And that's the way to do things. How many have formally debriefed the procedures with the anesthesiologist and the scrub nurse? So that's how we can have coronary surgery survive. That is my view.
So, thanks, Paul. Great points. I have 2 goals with those patients. In order of magnitude, the first one is that I want the patient to come back 30 days later at my clinic, shake my hand, and tell me that he or she is okay. That's the very first goal. I don't want them to die. The second thing is I want to do a repeat echo or whatever, nuclear, 3 months later and hopefully see an improvement in EF. I don't think arteriographs are part of that equation, to be honest. I do the simplest surgery. As you probably all know, those who know me, I'm a very strong proponent of multiple arteriographs, but not here. I think it's different. If you have a 50-year-old, you have viability, you expect things are going to turn around. Obviously, you know, you're going to use a couple of memories, maybe a radial. You think there's not going to be prolonged intubation. But look at the opposite. Someone stays intubated for 5 days. You got beta. Someone stays on levofed for 3 days, and you got a radial. It's not a very good proposition. I try, my first foremost priority is that the patient walks back to the clinic a month later. And if they fail their saphenous graft 8-9 years later and they have SVG disease, it's a success. You know, they live to tell the story, and then we'll figure it out then. But I think it's a very different equation than our usual patients.
Very good.
So we have a
Yes, sir.
question from the audience.
Joe Nora from the great province of Ontario. I have a perhaps ignorant question, but it is me seeking the advice of the experts regarding the mechanical circulatory support for some of these patients. In our province, where our economy is single-payer, government-funded, the distribution of funds for VADs and transplant has been established, long-standing, and so although we are 11 centers, only 3 of ours are actually funded for transplant VADs and such. And although the rest of us are doing excellent adult variable cardiac surgery of you know, varying degrees in valves and the rest of it, we have not developed the clinical expertise in heart failure. Now, I'm going to be the first one to answer or admit, in 15 years of this, my colleagues have tried to teach me how to judge the PAs and when to withdraw ECMO, and I still can't get it. And I have Steve Singh, who's this expert in transplant, who's taught me 3 times a year how to do it, and I keep forgetting it. And our cardiologists don't have that expertise. Impella seems to be this kind of in-between. And my question is putting these Impellas in for coronary surgery a viable option at a center that doesn't really have the clinical expertise to manage the heart failure in more sick patients?
Sure. So I got to use the Impella because I'm at a big shock center, and I'm a LVAD and transplant surgeon. So, and then it translated into my coronary practice. But I mean, I would say yes. I think it's a very straightforward device to use, and I know that. And I have my residents for a big teaching program too, and I take my PGY2 residents, and they can do the case skin to skin. And then, you know, you will.
But what about the post-operative management of that patient?
Right. So I think it's actually a very straightforward thing. And I know Steve Singh, and he trained me as well when he was in Boston, and he's a fantastic guy. And it's actually just keep it simple and just trust the hemos. The hemos don't lie. The echo will show you whatever it wants to show you. It's interpreted by the person who is reading it, but you get them down to a single low-dose inotrope. I love milrinone as well, and no pressors. You diurese them to what you think is a good, you know, weight. You're never going to you might not get them to euvolemia before you take it out. I think you don't have to. That can take 2-3 months to get some of these patients to true euvolemia after the neurohormonal cascade kind of sorts itself out. But you know, out of the acute shock stage, after the acute post-cardiotomy insult, you get them down to good hemos, a single low-dose inotrope. You turn the device down to P1, and if they look fine, if their hemos are fine, if their systolic does not, if their MAP does not drop by 10, then you will be okay to take the device out in most cases. And you wait for any end organ dysfunction to resolve.
I just have a question. Is this begging a trial here in mechanical
So there is a trial coming out. It's called the IMPACT trial. But as many of us know in the audience, it's been hard to show a benefit for any of these shock devices. Some of the cardiologists in the audience, I'm sure, could speak more to it, but there's this fun slide that goes around that shows all of the major shock trials, and none of the devices have really shown to be truly beneficial just because of the different phenotypes and how hard it is to randomize. Like, are you really going to randomize a 50-year-old guy who comes in with an EF of 10 to know support? And so they're put on these devices in variable stages of shock. Some people come in with lactates of 2 versus
I was
lactates of
thinking more about active therapies, 2 active interventions, as opposed to no intervention. Is that
Yeah, no, I see what you're saying. Yeah, that would be something
And
that...
particularly in this question, and again, it'll take organization, but it just seems that we've got something there.
Before we move on with the questions, I have another question regarding the impellers. I think we all learned it's an excellent device to come off pump if you have an issue. Is it a good device to assist you doing op caps in poor EF, or are there any issues with the position of the impeller while you start to rotate the heart?
So I think I personally don't do that in my practice, but I have spoken to two people who do. But also, I have operated on people who've had to go to the OR with the device in, and I simply pull it back into the LVOT, and it's easy as long as it doesn't cross back the valve. Now, the CP and the 5.0, they had the pigtail because people were afraid it would kind of, and the 2.5, the 3.5, they have the pigtail because it's a smaller device and everyone's afraid it will go through the lateral wall. But the 5.5, especially if you pull it back into the LVOT without having it cross the valve, it should not give you a problem. I have not had any issue with that.
But is there any experience with keeping them on the impeller while you do op cap and while you, for example, expose a lateral wall target? Because that could cause some issues.
Yeah, again, I personally, Faisal, do you have?
Yeah, I had another SCAD case. Seems like I tracked them when I'm on call. And Donna was our new addition to our team from Canada. Called me to help her, and this patient came in with SCAD and an impeller in the groin, and you could actually go on pump with the impeller in place, pull it back a little bit, and you can clamp the impeller, and you can do, on pump, cross clamp, complete revascularization, and then remove the clamp and hope that the impeller 3.0 is going to be fine, if not upgrade to impeller 5. But placing the impeller 5 is really, really easy. I mean, I've inserted 15, but Aaron Weiss and Ed Soltis, who's given one of the industry sponsor speeches for lunch today, he's done over 100. I do it in 30 minutes, they do it in 10 minutes. And they have a better feel for management than I do because their specialty is heart failure. So I don't hesitate to have them in the OR or help me co-manage, because there are nuances. So if you're not comfortable with using them because the volume is not there, I suggest you put them in if you can and if you're comfortable, and then transfer the patient out if it's anticipated to be a rocky post-op course. If you feel that the targets were great, there was viability, and you're just using it as a buffer, keep them at your institution. But if you're thinking, hey, this is tough, and the next day there's no much pulsatility, I think it's better to transfer those patients out. The other thing that was mentioned about Miranon, I love Miranon, and if you ever get in a situation where you're on a balloon pump, considering transitioning to impeller, I've got a little trick, and it works. I've never published it. Get a small syringe with a TB needle, put some Miranon, full concentrated Miranon, and inject into venous grafts. It goes directly to the target vessel. The flow will triple in that vein graft, and the heart will look totally different. Try that in your practice if you have to.
We have time for a few more questions. Let's make them brief, and we'll have brief answers as well.
John Castro from Minnesota. Obviously, you have these very sick patients, and sometimes you'd like to put the 5.5 preoperatively through the axillary, but with this kind of patients, there's a very big difference in a coding and a DRG when you put it through the axillary and then compare it when you put it directly on the aorta. Obviously, your hospital will want you to do the better thing.
So as of October 1st, the coding changed so that they're equivalent reimbursements.
October 1st?
Yeah.
Oh.
Yeah, because like I said, I'm a heart transplant and LVAD surgeon, and we have a big shock program, so I predominantly try not to open the chest unless there's some prohibitive reason why I couldn't go through the axe. And It is an expensive device, and my hospital initially was balking at, why are we using so many Impellas? We used to put these patients on ECMO, the DRG was higher. And then the reimbursement schema changed as of October 1st. And so now I can do AX55 without any pushback from hospital administration because it's DRG1.
DRG1.
Now, good point, Marissa. Can I just ask one thing? And I know that Niv might have something to say about it because you and I have discussed it by text message. The issue of possible risk aversion. We mentioned the STS star ratings. And for example, that case, the transfer of a failed biobental, that we revised those grafts. If that patient had died at our hospital, it would be a Cleveland Clinic redo cabbage death. And it would be counted as the referring center root death. How do we do those high-risk cases, at the same time maintain our reputation of excellence? So Niv and I have discussed this. Niv, were you going to talk about this or something else?
I have a different question, but
Yeah, we really have to close here in the next...
But I'd like to hear from Marissa quickly.
We can take this offline.
Marissa, how do you deal with those high-risk cases?
I have to say, Dr. Bakeen, I was reading your papers in preparation for this, so I was just taking... I agree with you. No, it's really hard. I'm the junior surgeon still 5 years in, and I get all the low EF patients because everybody wants to redo roots instead. So I have to really, I'm looking at my outcomes very closely. So
it's a very important issue.
Very stressful.
We had this in New York State with cardiogenic shock. We've gone over this. The New York State approach you should emulate.
Thank you. Just briefly, as both low ejection fraction and total arterial grafting or multi-arterial grafting determine prognosis, where does low ejection fraction trump arterial grafting? I mean, at what point in time is it not useful to do arterial grafting? At what level of low ejection fraction would you abandon it and just go to what Mark was saying, just get the patient out of the operating room?
Yeah, it's a great question, James. I think, again, where is the benefit of multiple and total arterial grafting? It's probably going to be 5+ years, right? The early benefits are probably based on confounding by indication. I don't think that vein grafts take patients down like flies early on. We could debate a whole day about this. But I think, again, what we're trying to achieve, given...
Do you have a figure like 30% or 25% or as a
they
whole?
They do, but there are some arteries that don't work as well, right? And I think we have to be careful that the overall applicability of, for instance, ARETA on the right or ARETA on the LED, or probably what's the best application of ARETA on the circumflex is not universal, right? So it may be in expert hands, but I think here the point is really to have the simplest, most efficient, quickest also operation. So where does it trump? Again, obviously a younger patient, someone who's younger than 65 or 60 who has viability, obviously I think we would all try to give them multiple arterial grafts, but we'd also be cognizant that they don't stay intubated for 4 days later and that they're not on 0.4 mics per kilo per minute of levofed, right? Which could impair what we're trying to do here. So veins may have a bit of an advantage.
Yeah.
One
Let's take the questions.
One quick for Faisal, actually. So I think I'll be brief. I think it's important. I think you shared with us the data and so on and so forth, but I think what we are missing is in the US, most of cabbages are being done in small community hospitals. And the point is, on the management level, who should not touch those patients rather than how to touch them? I think it's a relevant question. And then go back into the STS risk aversion. I think it's going to evolve from there. But I think this is what's missing here.
If we have to take this as a commentary, not a question, because Mark, we have to stop now.
It's good to keep us hungry here.
But it shows how good the session this was.